This video is brought to you by none other than Hire Heroes, you guys. Hire Heroes is your one-stop shop when it comes to virtual staffing and making sure that you have qualified talent with your business. One thing that I love about Hire Heroes, you guys, is they've actually gone through the process already of vetting and making sure that your staff member is well trained to best fit your needs. Whether you need help with social media work, posting things on your accounts, responding to people that send messages to your social media accounts, whether you need help with data entry or a multitude of other things that they're qualified to do, Hire Heroes has got you covered. If you're having trouble finding quality talent and number two, affording to be able to run payroll for that talent, Hire Heroes has got you covered with an affordable alternative to have a virtual assistant working for your business. There's a link down in the description of this video to where you can learn more about getting your own VA through Hire Heroes. I certainly recommend it. They're what we use in our business for all of our virtual assistant needs, and you will want to make sure that you check them out today. Hey, what's up, guys? Christian Brindle here, and I am back with another video with somebody doing big time things in our space. I'm here with Norma Johnson. I'm going to give Norma a quick little introduction for anybody that might not know her. Norma is a leading expert in the field of prescription drug savings and healthcare solutions. Norma worked on the pharmacy side as a licensed pharmacist in the retail sector for decades. And Norma now has founded in 2023 Strategies for RX Savings, built on the back of helping agents find creative and innovative ways to lower the cost of prescription drugs for their clients. Norma's doing some big time things, guys, in this industry, and she's making a huge difference in a lot of agents' lives, and in turn, making a difference in a lot of their consumers' lives and their clients' lives. With the ever-increasing costs of prescription drugs, I feel like the timing of this video could not be better. If any of you watched my video on Medicare supplements futures in the next 3 to 5 years with the increasing cost of prescriptions, Norma and I, are, in my opinion, on the same page on a lot of these things. And so first off, Norma, how are you?
I'm fantastic. How are you?
I am doing awesome. I'm doing awesome. Thank you for taking the time today. I'm really excited to have a good conversation with you about this. So first things first, for anybody that might not know who you are, go into a little bit more detail on your introduction, right? I talked a little bit about kind of, your introduction, but talk about how you went from pharmacist into the insurance world. Talk about that a little bit.
Well, just to give you a little bit of background about me, I spent 20 years with CVS Pharmacy. So I started in 2002, in September of 2002. I was still in pharmacy school. So excuse me, I graduated from pharmacy school in 2007 from the Ohio State. We have to throw in the there. But Ohio State, so they're in Columbus, Ohio. And, I set off on my pharmacy journey. So I'd been there since 2002, but I wasn't a pharmacist until 2007. But of course, you have to work in a pharmacy. I'm in the pharmacy school. So I did all my, internships and all of that. And of course, being in the pharmacy for so many years, I was around, God, I hate to say this, I was around before discount cards. That's shameful to even admit. But I was, and of course, as discount cards came into play at that time, you think that was before Part D. We had a lot of people that didn't have insurance, right? They didn't have prescription drug coverage. Our seniors didn't have prescription drug coverage. So of course, they were really at the mercy of the pharmacy. And at that time, when you went to CVS, if you didn't have a discount card and you didn't have insurance, you just paid their usual and customary price. That's the way it's set up. All pharmacies are required to have usual and customary prices. So you could go into CVS and pay one thing, and you could go down the road to Walgreens and pay something else. The discount cards kind of leveled that playing field for people that didn't have insurance. So, and of course, that's a story and a training all itself, is how do discount cards work. It essentially makes PBMs, or pharmacy benefit managers, compete, but it's very intricate. There's a lot of stuff going on there. So, as discount cards came out, I was able to save more and more people money. And then just over my career, it was all about trying to help the patient save money. If somebody came in, even if maybe they had an employer coverage, maybe the inhaler, I remember somebody that was coming in, he was going to have to pay like $300+ for his Advair inhaler. Well, I knew it had a manufacturing coupon card. So I literally was able to log into the system and print off a manufacturing coupon card, which can be used with commercial plans, right? Can't be used with Medicare, but they can be used with commercial plans. And I was able to pony that with his insurance, and he paid zero. If you do not think that that man was happy as hell walking out of that pharmacy, knowing he had walked out and didn't pay a dime for that inhaler, we were heroes. Well, and of course, I called ourselves, at that time, we had all female technicians. So we were the queens of drug savings. So it was a mission. So it was like a passion. We were all very passionate. We would search everything to try to save people the most money. And it just ended up growing into that. It was ironic because then the discount cards came out. Nobody ever paid usual and customary anymore because why? We had a discount card. Instead of paying CVS's $11.99, we could drive the price down to $2. Well, of course we're going to do that. Now, of course, it would have been better off if CVS would have actually explained to us a little bit of how pharmacy worked. And then we would have known, well, wait a minute, we're costing CVS money because we're driving down their profits. But hey, they didn't educate us on it. So it's like, well, your loss, maybe I would have felt sorry for you, but I doubt it. I could have them. So I did that for years. Of course, CVS did come in and say, stop taking discount cards. And of course, I looked at them like they had three heads. And it's like, well, make me. By then I had been around for quite a few years and I held quite a bit of weight. I was kind of like, I was their heavy hitter that they sent into problem stores, and I did it in a lot of states. So it's like, don't mess with me. Go mess with the store down the road. Don't mess with me. So they tried, and of course they failed, and then they had to embrace the coupon cards. So it wasn't long after, and it's like, well, we told you already. We were doing the right thing because it's driving people to come to us because they knew we were saving them money. So, that was just where the passion all came from. And of course, retail pharmacy since 2017 just is getting worse and worse and worse. And the pressures are getting higher and higher and higher. They keep cutting back our staff hours. Anybody that goes into a retail pharmacy sees that. So they cut back our staff hours, but they ask us to do more work. And so I wasn't happy anymore. I'd hung in there for as long as I could, but I was no longer had the time to help people save money. And when that happened, it's like I started looking for something else. And then COVID started, right? So it was a collection of when COVID first hit, my mother ended up with lung cancer. So I had already pulled back to what we call PRN or just as needed. Because I was running 4 hours south of where I lived to help take care of her. And it kind of gave me the time because that's when I started getting licensed for Medicare. The crazy thing is, as a pharmacist, I didn't even know there were Medicare agents out here. I had no clue. There was never an agent that come in to introduce themselves. We would try to help people on Medicare.gov. We didn't have time for that. No CVS has time for that. No Walgreens has time for that. Maybe some of the grocery stores, perhaps, and independents, but we didn't have time for that. It was astonishing that I didn't know until I had a conversation with a friend of a friend. And she did Medicare. And it's like, oh my God, I didn't even know there were agents out there. How does this work? So of course, then that's when I ended up getting licensed. I took that time when my mother was sick and during the middle of COVID, trying to figure it all out. And I took a lot of time in studying Medicare. It was funny because I always said I spend more time studying Medicare than I feel like I studied for pharmacy. That's a lot. That's a lot. So I feel for agents especially trying to get into this industry. there is so much to learn on the Medicare side and the plan side and the compliance side.
Yeah.
Not even talking about the drug side. And the
Yeah.
drug side is bigger than the rest of it, but gets almost no attention, right? We spoke about that, the fact that it's crazy to me that agents are not required to have prescription drug training. And I'm not talking about learning what the drugs are for, but just understanding the different parts and how things work. What is a formulary? How can the pharmacy benefit managers manipulate that formulary? And who does that help when they do that? And I think that's what we're going to see a lot with the Inflation Reduction Act. So, I got into Medicare to give me time. Now I can, if I want to sit with a senior for 2 hours, I can do that.
Yeah.
And so, of course, I've been happy doing that. And I did very well for the couple of years. My mother passed December of 2020. So I really don't feel like I got started into Medicare until January of 2021.
Yeah.
And so for 21 and probably 9 months, I mean, not quite 9 months of 2022, I've ended up with like 350 clients. That's not bad. And I keeping track of them. I say that, but that's how many I know I have. I probably have more because I kind of shifted, right? So last spring is when I had designed a presentation I called Tips to Find Savings on Prescription Drugs for myself. I didn't design it for anybody else. I designed it so I could give it to groups. I have a 55 plus community. I wanted to do it to educate seniors and other people on Medicare that, hey, there's a lot of savings out here.
Yeah.
Let me help you find it. And I did it, and I started having a lot of success. I mean, I could literally put on that presentation, and I mean, I'll max out the room because people are suffering with the cost of drugs. They want to come and learn how to find savings on prescription drugs, right? The title itself makes somebody interested in coming. It just, after that, it just started bugging me. It's like, you know what? That's great that I'm doing this, but I'm one person.
Yeah.
I need the masses. There are people suffering everywhere in this country. How do I go help them? And that's when everything shifted. So I literally stopped promoting myself as an agent. I converted the presentation to where it could now go to agents. So I started thinking, okay, well, I'll sell my presentation to agents because now I'm not marketing myself. I'm focused on this. So it's like I'm no longer growing my book of business. So I started that. And then I thought, you know what? Well, agents don't know anything about drug savings. Not everybody. Some do. But the vast majority of them don't know a thing about the different types of strategies or when to use it, when it would benefit them to use it with a client and how to best do that. So then it's like, well, now I'm going to have to do videos, which I hate doing. And then, of course, then I have to have a platform to do that. So, of course, I used your good friend, Eric Fierro's CRM to kick this thing off. And he was definitely worth his weight in gold. I owe him big time because he worked on creating that platform for me. I'm not technologically inclined. So I suffer. I can do little things, but then I need help. And he was a big help on getting that launched. So we launched actually what we call the university, right? RX Saver Pro University, for lack of better words on that. But it's even changed since then. It's so much bigger than what it was. I had to move it to a whole new website. So I had to have a website built. I did that between January and May. And we moved everybody that was current members onto the new platform on May 31st. And then we kicked it off on June 1st. But so, I mean, it's become so much more. Over the winter time, because again, I'm an agent, right? I'm an agent that happens to be a pharmacist. So I look at it from an agent's perspective. Agents that want to help somebody are out there, but they need help, right? It's all about speed because time is money. So in looking at, well, how do I from even myself, but how do I know, or how do I tell agents or educate agents on, it's not just the strategies, how do I give them the tool to find what they need quickly? So then I sat down and started writing a database. Oh my God, the hundreds of hours that took. For the wintertime, I barely slept. I would wake up, I'd go to bed at 11, wake up at 2 and think, I got to go back to work, because the home office, right? You're right here.
Mm-hmm.
And so I literally developed a database that I call it Strategies RX, but it is built by me for agents to make you extremely fast on finding drug savings. There's almost 12,000 entries into that thing.
Wow.
And of course, we have to maintain it. So in looking at the database, it doesn't have, you can do a search on the drug. So if you want Xarelto, cool, put in Xarelto and it'll pull up all of the different ways to save. Is there patient assistance? Yes, there is. Is there a discount program from the manufacturer? Yes, there is. Can you potentially get it for a really good price from a certified Canadian pharmacy? Yes, you can. So if somebody's interested in that avenue, cool, fine, whatever, it's up to them. Is there patient assistance, or not patient assistance, but a grant? Yes, there is, but only one grant and one diagnosis. So it's limited there. But the next thing is like, okay, does it have patient assistance, or does it have savings? Yes, it does. Well, what's the criteria? Well, if somebody doesn't give it to you, now you got to go find it, right?
Yeah.
You could say, well, Needy Meds is out there. And I say, good luck. If you've got the 2 hours to go figure out, because Needy Meds is not going to tell you the criteria. If you ever go into Needy Meds and look up a Xarelto, it doesn't tell you point blank what the criteria is. You have to do a lot of searches, right? You have to go into things. You have to look. Well, again, time, right? Time is money.
Yep.
Well, if somebody just gives it to you in your right, it's in the database. You look at Xarelto. You look at the manufacturer. There's a phone number for the manufacturer. There's a live link for the manufacturer. And by golly, there is the criteria. I don't just give you 500% federal poverty level. Well, crap, what is that? Right? That would be another thing. Now, what is that? Then I'm going to have to go back out of that screen, go into another screen, figure out what's the federal poverty level. Plus, I'm going to have to calculate it. I give it to you. You literally could do this in 10 seconds. Yeah. And then, it's like, all right, well, where's the application? Not all applications for patient assistance is easy to link, because a lot of times they're embedded in things. So what I do is, all the university members belong to a private Facebook group, and that's where I can literally link files. So all my patient applications are on the Facebook group under file. And you say, well, I need Xarelto. Okay, cool. Scroll down. Email it to your client. Say, print this off. Take it to the doctor's office. Easy as that.
Powerful.
And it takes you seconds. You didn't have to do any. You literally just did a quick search. So it all stemmed from me being an agent, thinking, how can I make agents better?
Yeah.
You think of what is my mission? Right? What am I getting out of all of this? Well, my mission for really Strategies for RX Savings is to reach every person out there that's struggling to afford their meds. There's a lot of people out there struggling to afford their meds. I mean, I barely can go out of the house now, and it's like you go pick up a few groceries, $166. I just did it the other day. Yep. 3 little bags of groceries from Kroger and 3 packs of water. And I looked at it, and it's like, how did I just spend $166?
I walked in for one thing. Yeah, I've been saying recently that in today's economy, you can't get out of the grocery store without spending $100 to $150.
No, you can't.
For anything, practically.
Everything is going up. It's nuts. And you have to look around and say, how are people affording this? If you look at the people that we're trying to help, you don't have to worry much, and you don't want to segment people, but you kind of segment people. You have the people that are dual eligible, right? Mm-hmm. Then you have the people in the MSP, you have people in LIS. I don't worry about those people, right? Because they have already reduced copays. So if somebody's on a dual, okay, that's cool. You have your plan, you have Medicaid, you don't need to worry about much. You don't even really, honestly, have to worry too much about the formulary. So I try to tell agents, when you're dealing with that group, you don't have to worry much. Just put them on a good plan. Don't worry too much about their drugs, because even if something's not on the formulary, the way the pharmacy processes it, we run it through the carrier first, the MAPD plan first, and then it gets moved over to the Medicaid. So if you have somebody on Humana and a drug is not on the formulary, they're going to reject it. The pharmacy is going to bypass that one and send it directly to Medicaid. Medicaid knows we have bypassed the primary. They know that, and they usually will let it go through. Now, if we send it straight to Medicaid without that primary, they're going to reject it. But as long as we connect them right, it lets it go through. People on LIS, that's a little different. If people are on LIS, it has to be on the formulary. So you do care about their formulary in that case, but you don't worry much about the cost. Even people starting 2024, as I'm sure you know, people that are partial LIS are now going to be full. So it's going to go up to 150% federal poverty level. That's cool for that group, right? So don't worry about those people. Worry about the people that are just above it, because they're not bringing in enough money to buy groceries, pay their utilities, and God forbid we have too many seniors either still with mortgages or living in apartments. How can you possibly afford the rent? They can't. And then these apartments keep boosting up. I had a client this last year. She's maxed out, and her apartment complex was raising her rent by $300. Thankfully, she went and negotiated and come up with a better deal. But I mean, she'd already come off a med sup because she couldn't afford it anymore. And I put her on a zero premium MAPD, but then they want to raise her rent by $300. She brings in $1,800 a month. How are they going to survive? And if you've ever had somebody, and God knows I've had too many people break down in front of me at the pharmacy because they couldn't afford to pick up their med. They're choosing between medication or groceries. And it absolutely is crushing to the soul to have to see that. It shouldn't be that way. And I could get on a rant about PBMs all day long. There's no love lost there. They know it. I'm very blunt. I have conversations with a lot of people, and they know it's like, I do not like what they're doing, but unfortunately, that is what we have, and we have to deal with it. So my passion is to find those people, and RX Saver Pro University, which is on the backside of Strategies for RX Savings, is just a platform, right? So it's where it's a platform. I can put the training. I have the database. I have a white label discount card that is owned by a very good friend of mine. There's a lot of things in the works that I can't necessarily talk in detail about. We're trying to come from the backside to bring prices down for drugs that I know here from agents that are problems. So if somebody's looking for a drug, maybe it's a generic, but it's a tier 4 on most Medicare Advantage plans, and it's still high at GoodRx or Single Care, can I get the price better using saveonrx.net? Well, I have connections there. We have a PBM. We have power to get to the manufacturers. Can we give them numbers to drive that down? So there's a lot of things on the backside that I get involved with, because we're on a mission to figure out how to lower prices. If we're expecting the government to do it, this Inflation Reduction Act, oh my God. I mean, definitely people want to watch my training, but that is going to harm far more people than it's going to help.
Let's talk about that a little bit, right? Because I feel like there's a very small amount of education right now about the true implications and the domino effect of sorts that this Inflation Reduction Act is going to have. I think everybody's seen $2,000 cap and thinking, oh, that's great. Talk a little bit about some things that agents might not know that can really be an effect of that domino effect. I feel like that's something that isn't being talked about nearly enough.
No, I don't think so either. And it is a very serious thing. So will it help some? Yes. So the Inflation Reduction Act, and you have to look at, when did it come about? You have, and I'm not bashing either side. All politicians, to me, they all talk out of both sides of their mouth because they have to. It's all about
Agreed.
deals, right?
Yep.
They have to deal. The administration needed to put something out before an election that was pretty, right? Drive down the cost of meds, drive down the cost of meds. It sounded fantastic. They push it through without looking at the back end of it to see what kind of ripple effect is this going to have. So the inflation rate, and I still to this day can see the president walk out and say, we're going to drive down the cost of meds. And I want to jump in the TV and say, for whom? For whom are you going to drive down the price of meds? If you look at the chart that I posted on my training, it clearly shows you the difference between 2023, 2024, and 2025. Between now and 2024, the only thing that is different is that 5%, right? The 5% when somebody reaches catastrophic. So cool for the people reaching catastrophic. The vast majority of people get into the gap and never get out.
Yeah.
Right?
Yep.
And of course, that's the most expensive place to be because brand names are 25% of the cost. So every $600 med, which is almost all brand name meds, are 600 plus. That's $150 a month per medication. So, it's not helping the masses in 2024.
Yeah.
But carriers and PBMs are gearing up for 2025. And then you have to look at some other rules that are coming in because they're going to be restricted on how much they can increase premiums. Now, I couldn't remember exactly when, and I hadn't had the time to go back and look. Well, apparently it's 2024 because we're seeing massive increases in premiums come in 2024. Are we not? Yes, we are. Way above the 6%, as it's like 6% of what they're going to be allowed to. So they're going to hit it right now. They're going to hit it going to 2024, seal in that big premium. So then they'll only be able to go up 6%, right? After that. Yep. But they're going to hit as high as they can before then. They're also making changes, of course, we know, to tier 3, and that's not pretty either. Essentially, what they're doing is they're forcing. So what are the good things about the Inflation Reduction Act? Medicare is going to save a ton of money. Medicare is going from 80% to 20%. Most agents do not realize that when somebody is in catastrophic, who's paying? They think it's the carrier. It's not the carrier at all. It's Medicare. Medicare is footing that bill. If you look at the chart, the only skin that the carrier, the PBM, I shouldn't say carrier, because to me, the carrier is different than the pharmacy benefit manager, even if they're like even Humana. Okay, CenterWell is the PBM and CenterWell Pharmacy, and then you have Humana. But so you end up where we are today, they're 75% when it's in initial coverage, right? Well, what gets tabulated towards that? The cost of the medication, because the client can pay up to 25%, the PBM pays 75%. Well, it's all based on what is the price. The estimated drug costs that we see in our plans is a completely fake price. Completely fake. There is nothing real about that price because for every brand name drug, we know that they are getting a rebate.
Yes.
But we don't know how much rebate because it is covered in secrecy. You will get a secret out of the government before you get that number. Somebody will be killed. I mean, honestly, I hate to say it like that, but you're not going to get that number. They're not required to give it. They will not give it. It's not happening. We can speculate. So it very well could be 30 to 50%. But are they passing it down? No, they could. If they had hearts, they would, but they won't. They're going to put it in their pocket. But what gets tabulated is that fake price. So maybe they say the price is $600. Maybe they're really paying like $325, but $600 is pushing somebody through the initial phase into the gap. because the PBM wants people into the gap. They want them through the initial phase as fast as they can get them there.
Right.
And they do
right.
that by those big prices. It's fake, yes, but get them into the gap, because then they go to 5%. If you look at the chart, they go to 5%. Well, guess what? They get to push off to Medicare for pharmacy fees. It's not disclosed, but they can easily say 5 to 15%. Oh, it's pharmacy fees. Well, guess what, Medicare? Now you get to pay that too. So now they're out free during the gap. They're out free essentially when they get to catastrophic right now, because it says, well, okay, they're responsible for 15% today, 20% in 2024. Well, again, write off the pharmacy fees. Now you're almost down to zero. And it's all on Medicare, right? Well, 2024, it's the same way. It's not going to get any better. It's just that we're going to see their bigger premiums, and we're going to start seeing them manipulate a little bit, not much, but a little bit of the structure of things. In 2025, all hell's going to break loose.
Yeah.
So, Medicare is going from 80% to 20%. The manufacturer, I don't know who they paid off. Something happened, but they're going from 70% to 30%. They have 2% and then they have 20%, right? So 10, because we get rid of the gap. So now we're going to have deductible, initial, and catastrophic, right? So, we don't have anything that calls the coverage gap is gone. So, of course, they get through the deductible if they have one. Now they're going to be in still 25% in the initial phase until they reach $2,000. And that's out of pocket for them, because, you think the gap, right, when you're in the 25% to go above, you're also getting to add, because that's where we're talking. When you go into catastrophic, that's troop. The rest is, I call it progression through with the initial phase. That's not troop. The only thing getting counted is what the client is paying. So the deductible they paid, and then, of course, the 25 up to the 25% they paid. Okay, that gets counted towards troop. Not a dime that the carrier, the PBM, is paying gets counted towards troop. So you have to, and I always teach agents, think troop, think exit. That's what that means. It's the exit out of the initial phase or the gap to catastrophic. That's troop. So, you think in 2025, the 65% that the carrier is paying doesn't count. So it's the deductible you're paying. Now you only have 10% being counted, right, from the manufacturer. That would get counted towards troop. So, it's just frustrating how they set it up. So is it going to help some? Sure. Is it going to hurt everybody else? Absolutely. Because the pharmacy benefit managers are not going to take a cut in their profit. They're not going to do it. And you are sadly mistaken if you think they are. They're going to spread it just like everything else. Raise the price of fuel, right? Of oil. It raises our gas prices, which now means we pay more at the pump. They're going to force more people to hit that $2,000. They're going to spread that amongst everybody.
Yeah, I think about it from the standpoint that the average person that wouldn't have hit $2,000 in out of pocket previously in the old model is now going to much easier be thrust into that $2,000 number. So as you mentioned, it increases the cost for the masses. One thing we talked about before we actually went live on this was helping the minority, hurting the majority. And that's what I think of when we have this conversation. It's absolutely mind-boggling. I was having a conversation with an agent pretty recently, and I said, think about it like this for a second. If you think that, what are insurance companies? Smart, calculated, profit-driven, right? And so are the pharmacy benefit managers, by the way. And so I look at it from that standpoint, like they're going to find, and it's pretty, when it first came out, there were some elements of it that I was like, there's some things I think could potentially happen with this. And, everybody was celebrating when the bill first passed. And I think, I was pretty vocal about it. I think, you were certainly very vocal about it. I'm like, let's pump the brakes a little bit. Why do you feel like there isn't a whole lot of conversation happening about this right now on the carrier level. I have some theories of it, but I'd love to hear your thoughts on it. Like, why is this not being talked about a lot right now?
Well, I mean, they're still trying to figure, they're trying to digest it, right? I mean,
Yeah.
I've put people on the spot in person, and although they can't say anything, they really don't know until the numbers fully come out, because it's all every year they go back to the bargaining table with Medicare,
Yeah.
right? It's how they go in and they bid every year. And then they figure out, okay, how much lower are we from the base to how much? So how much can we get back? Because they get started. If you ever want a good assignment, go dive into that mess, man. You need booze to get through that. You're not going to do it sober, because it'll drive you crazy on how they negotiate things. But why are they not talking about it? They know it's going to be ugly. So the PBMs. Or not the PBMs, but the PDPs are the ones that are going to suffer the most. So that your piece the other day about the death of med subs, it's not that med subs are changing in a bad way. They're not. We love med subs. But the PDPs are going to become so pricey, it's going to price people out of the market, right? I mean, you're going to end up with, take a look at what Aetna's doing, right? How much is their big drug plan? How much is that plus plan coming into 2024? That's not pretty. No. Add that on top of the Part B premium for them, and add that on top of now the Medicare supplement. You're getting way up there when somebody's at 65, when they can make the choice to get on a supplement, right? Without underwriting.
Yeah.
It's going to get costly. Where the Advantage people, there's more wiggle room, more wiggle room. So the PDPs get paid very little by Medicare. There's more fueled by premium. So it's a premium that counts, and then they're kind of manipulating and using utilization management to kind of control costs. So that's one set. The Medicare Advantage people are going to use this totally to their advantage for now. So 2024, you're going to see a little bit of manipulation. You have to think they're not going to lose money. So how are they going to do it? You're going to start seeing definitely percentages in tier 3. I don't know if we're going to see any flat copays without a big premium. If you want the plus plan for Aetna, you'll have a big premium, but you'll have a set copay. But you're stuck with that big premium. That's not far from double where they were, right? So I mean, it's way up there. The MAPDs are definitely paid more. There's a lot more wiggle room. They're paid a lot more money by Medicare in order to fund those. So they're going to have more room. Plus, they're going to have some benefits, right? Mm-hmm. I would much rather have somebody dish out and give less dental, less OTC benefit, less everything, and let's keep a robust drug plan.
Yeah.
But they will try to find a balance, but somewhere something's going to give. It's going to give with the PDPs far faster and far uglier than right now for the MAPDs, because there's more money in those. But the Advantage people, they're going to use it totally to their advantage. Yep. So in 2024, we're going to see a big shift of people moving into Advantage plans.
Yeah, I totally believe it. I totally believe it. Like, I have been saying for a few years now that if you look at the change in the market, right, in the trends, and I think this is just the latest, the government, or maybe we don't even say the government, we say CMS, the carriers, all of what I would call the powers that be, would infinitely rather somebody be on an Advantage plan versus original Medicare with a Medicare supplement plan. It's the reason why regulations push in that direction. It's the reason why there's a lot of reasons, but I think it's just the latest, push, I think, to increase Medicare Advantage market share and decrease original Medicare market share. And I think, when I made that video about the death of Medicare supplement, I had maybe 5 or 6 people slide in my inbox, and they're like, you sound like a conspiracy theorist. I'm like, no. I'm like, if you've been paying attention, this doesn't come as a surprise. It's what they want. It's what their ultimate goal is. Managed care model.
Yeah. Well, and I had somebody say, well, that's a speculation. And it's like, well, yeah, I'm using 20 plus years of experience in this industry. Plus I'm in this every day, all day. And I understand the pharmacy benefit managers and that entire system extremely well. Yeah, technically I'm looking in a crystal ball, but it's with a lot of knowledge. I'm not just throwing something on the wall to stick. The stuff that I'm talking about that is going to happen, I don't want it to happen. Yeah. Again, I'm trying to make it to where our grandparents and our parents don't have to go without their medication. But unfortunately, we're going to get to a spot, and when we get to 2025, and again, it's how they do things. So if you look at how a manufacturer, how a pharmacy benefit manager buys drugs today, and I use this example because it's actually been proven the manufacturer has done it this way because they were proving it to themselves. So remember, we're still in 2023 going into 2024, where the PBM wants to push people through, right? The initial phase into the gap. The gap is still there. So how they buy drugs today, you could have a manufacturer come out with the same drug, but they're going to give them two business proposals, right? They're going to give it one with a high price, high rebate. They're going to say, okay, but you can have it this way with a low price, low rebate. Which one do you want? 100% of the time, they're going to take the high price, high rebate. Because again, they could care less about the price because that's what's getting somebody into the gap. They only care about that rebate because that's secret and they get to put it in their pocket. Now in 2025, they might start caring a little bit more about that price. So now they're most likely going to say, okay, well, we want the low price, low rebate. Well, keep in mind, I said that the manufacturers are going from 70% to 30%. There's going to be some deals made there. So they might buy in the lower cost, but they're still going to be, they're still going to be saving money because I guarantee they're not going to let the manufacturers out with that. They get to call the shots. A manufacturer needs the PBM in order to be on their formulary. If they're not on their formulary, they don't get to move their drug. It doesn't matter that you just came out with a cure for a particular type of cancer. If it's not on the formulary, you're not going to move it. So the pharmacy benefit manager gets to pull the strings, right? But it is going to shift that. So we're going to see formulary shrink because they're going to have to, right? They're going to have to. We're going to see more what's called utilization management. So more PAs, more step therapies, more restricted meds. I mean, the list can go on, and more quantity limits, hurdles. I call them hurdles. It's like, what else do I have to do? I've they're going to do things in order that's going to put roadblocks. And I've seen a letter from one of the senators. The government's aware, but I saw a letter where they're kind of throwing a warning out, like, all right, for the pharmacy benefit managers, it's like, all right, don't step in the way of somebody's treatment. Don't step in the way of their wellness, right? Well, they've been stepping in the way of their wellness since the beginning of time. Yeah. But they're going to do whatever they have to do. So we're going to see, are the carriers going to talk about it? Are they going to... What did Caremark do when they raised their silver or their Smart RX plan? They took it away from us, right? Then they moved it to 25% in tier 3. Yeah. We weren't looking, right? Because it wasn't commissionable. So we're not paying attention. We're just putting them on somebody else or something else. And in the people that were fine, right? Because if we already have them on the PDP and they're fine at that low cost and we're not paying attention to what the change was, I looked at it. I was at a client's house. I about died. I right on the spot. I opened it up. Well, when you open something up, the first thing you look at is the right-hand page, right? Because typically you don't look at the left first. You look at the right. And so you see the premium, and the premium barely went up, right? So then somebody's, oh, well, that's still good. Close. You didn't look at the other side of the paper.
Right. Didn't look at the benefits.
mean, look at the comparison. That's when you see the 25%, so it's a lot of them are not going to want to call attention, because what happened there is you had a lot of agents saying, well, it's still a low cost plan and my client's only on tier 1 and 2. Well, they are today. You have 365 days to get through. Now, what if they end up on one of those tier 3 meds somewhere in that? And they're going to call you and say, what the hell? Why is my price $150? Well, it's 25% of the cost. Well, I thought it was a flat copay. Why didn't you tell me? Well, because I was too busy, right? Mm-hmm. I mean, you could have easily had handled that. The agents could have handled that better. I was screaming at the top of my lungs, get your people off that plan. I moved 50 people off of that plan. I didn't have time. I was squeezing it in edgewise. I was trying to get other business, right? This was last AP.
Yeah.
And I didn't want to have to take the time. And of course, Caremark knew I wasn't happy with them, because it's like, you're wasting all of our time. We're doing double work. Now we got to move everybody, and I put them on the WellCare plan. Well, guess what? I get to do this AEP. But now, and I told everybody, it's like, we might have the set copay for this year. We're going to be very fortunate if we have that in 2024, but I doubt it. Well, then it happened. So now I've got to, what am I going to do with them all now? I got 50 plus people I got to move now, that are sitting on PDPs. How many of them are going to end up saying, I can't afford the prices anymore, the premium, let's just put me on an MAPD. What if it's not their best fit?
Yeah.
Mess. It's a mess. So, I mean, I'm big on trying to find alternatives. So, of course, I've been in the drug savings world. There's a lot that agents can get. At the end of the day, how am I benefiting? One, I can sleep at night because I know people are actually helping seniors with their drugs. Two, by having the university, a lot of my training, my database is worth that far more than that $50 a month. It's not going to always stay there.
Yeah.
This is just because of this podcast that I'm even saying this. So if somebody doesn't hear, they're not going to be promised anything. But the $50 a month being ridiculously low, if people join before October 15th, so midnight, October 14th, I'm printing a list of all university members. If you are an active member before October 15th, starting at 12:01 a.m., I'm going to freeze your rate at $50, and it's never going to increase. I promise it's going up, but it's not going to go up for those people, because to me, I need to reach agents so I can reach seniors. You have to keep in mind, these people are not my downline, right? The agents. I do a lot to help them. I'm on calls and Zooms. I have people that send me really nasty drug lists that I'm trying to help them. It's not just me. You think, well, you can hire a VA. I can't hire a VA. I have to hire a pharmacist because I need a certain skill set.
Yep.
My lowest pharmacist costs me $50 an hour. I have to be competitive in order to be able to utilize them for what I need. I need them to help me with the database. I have somebody writing a curriculum and a certification test right now, because I have a lot of other big things happening. I'm going to be partnering with carriers. I'm going to be partnering with a lot of healthcare facilities to actually do presentations, my presentation for their patients. I can't do those. So, of course, I'm going to be using, I just asked my university members, it's like, okay, I need to know who has center wells by you, because we're getting ready to crack a deal. So it's like, I'm going to be given an opportunity for certified university members. So I say certified, meaning pass a test. Just go in and do some studying. If you need to do a Zoom, I'll do a Zoom. I'll teach you what you need to know, but you need to at least show me that you're going to take the initiative in order to want to learn how to do this. Because if I'm putting my reputation on the line with places like Centerwell or Oak Street or any other healthcare facility, I don't need you to screw it up, right? So I need to know enough, and then I'm there to support you. But it's going to give them opportunities to go in and do the tips seminar for patients. And they're allowed to, of course, have permission to contact sheets and business cards. And it's whoever So I'm trying to make it to where it is a university member, because understanding drugs and the savings and how it affects seniors is important. So if an agent is in there right now or trying to get in there, it would behoove them to be part of the university, because of course you might not have it in the future if you're not, because it is important to actually have this knowledge. I mean, in everything we do, we have to have some training, right?
Absolutely.
But I'm not making anything off your book of business, but I guarantee, I was on a Zoom call with an agent. She's about 3.5 hours from me, still in Tennessee, but about 3.5 hours. And I've been asking her for almost a year. It's like, are you in that 55 plus community yet? And you could tell she was scared, right? She's just not confident. And it's like, I'm here to support you. You just call and find out who that lifestyle director is, right? And I even gave her a copy of the tips presentation. I gave her a copy. I didn't charge her for it because I need her to get unfrozen. That doesn't mean everybody come at me for a free copy, but there's a 55 plus community, and I know there's a lot of seniors struggling to afford their meds. I need you to get unfrozen and go in there and introduce yourself and get to where you can do that present. I will come give that presentation on your behalf. I will spend my money to drive the 3.5 hours one way to come and give it, so that you can see how it's done in person and you get all the leads, because I have nothing to do with that part of it. And she sent me a message before we got online today. She had a conversation. They asked for a copy of the presentation, because in that location they didn't have a lifestyle director, but they wanted to see what it looked like and see if it was something that would fit. Oh, I guarantee she's getting a call back. It's like, okay, just don't book it in these particular dates because I'm strapped. So anything other than that, just let me know when I'm coming, because of course they're going to want it. That presentation's fantastic.
Yeah, absolutely.
But it's like, I need them unfrozen. Go give that presentation. You want to talk about, I need leads for AEP?
Yeah. I mean,
get some initiative.
That is so much tremendous value as well. I think I've always told people, like, for that amount of price point, you guys, if anybody's watching or listening to this at $50 a month to be able to be grandfathered in, if it helped you write even one additional app a month, you probably have paid for the next 6 to 8, maybe even more. Maybe I mean, if you write one extra true up a month, you're paying for the year.
Yeah.
In it, the amount of ROI
if you're not
that's
doing
possible.
Multiples of that, you're not working. You're not doing anything.
Yeah, that's the bare minimum. That's the bare minimum, probably, that it can help grow your business. That's a tremendous deal. So valuable. Guys, what we're going to be doing also in the description of this video is we're going to be linking that down in the description. So if you want to get in on that while you are able to, as Norma said, right up till October 15th, October 14th, the night of October 14th is the deadline. We're going to be throwing that down in the chat or in the description of this video. I encourage you guys to jump in on it, because that is something that, for one, will help you stand out. Hardly anyone in your market, no one in your market will be doing the same thing. So you'll be unique, and you'll be providing a huge service and a tremendous amount of value to your clients. There is no more complex part of this business than the prescription coverage, like, not by a mile. And so what Norma's providing is necessary, valuable, and everything else in between. So yeah, guys, go check that out. I encourage you to. We're going to throw it down in the description. And that's tremendously generous what Norma's offering right now.
Well, and I mean, my goal is, as you can tell, I'm not trying to get rich, right?
Yeah.
I'm trying to reach seniors, and my best avenue of reaching seniors is through the agents. So, I mean, I work night and day helping agents all over. I've got a lot of university members already. And like I said, I hate to call it a university. It's a platform, but it's also access to me. It's access to about 9 other pharmacists inside of our private Facebook group. And that's going to continue to grow other opportunities as I work deals on the strategy side. My whole focus is to get trained agents into all of these facilities doing these seminars. And I'm not going to say a heck of a lot, but there is another seminar that I'm in the middle of writing. It takes a little bit to do this. I have to be extremely creative. And when I get that one ready, it's going to be the first of its kind in this industry. And I have sent a message off this morning saying, okay, can this PowerPoint be somehow attached to the back end of the website? So somebody has to be a university member. They have to be logged in, so they cannot share it, right? And then they can give it wherever they want to. And it's going to be free. And it will be, it's like I said, I mean, there's a lot of, because keep in mind, my tips presentation is not a Medicare presentation. It's been cleared by Premier. It's not a Medicare presentation. Great. Nobody has to report it, right? Now, I still say do things in a compliant way. Come on, cool. Let's be cool. We're dealing with seniors, so don't be deceitful. You know, do your permission to contact, do your business card, but be chill, right? You know, this other one, I want it to also be not a Medicare type of presentation. If it turns out to be a Medicare presentation, then I have to get it cleared. But whether I get it cleared or whether it doesn't end up needing to be cleared, I want to be able to give it for free. And university members are going to be extremely happy with me. Because, I mean, have we had enough Medicare 101s, right? That targets a certain amount of people. It affects people who are getting ready to turn 65. What about people 65 and older? What are you giving them? I'm just, enough of the hints because it's not done yet, but I'm working really hard to get it done and ready by September 1st.
I love it. I love it. Norma, this was awesome. I want to be respectful of your time because I could probably keep you on here another 2 hours and I don't think we'd run out of things to talk about. Guys, I encourage you to jump in on Norma's program. I think it's incredibly valuable. It's something that you need to have for your clients, and it's an opportunity that probably won't be available again. So as I mentioned, check that link out. It's going to be at the very top of the description. It's going to be easy to find for you on this video. And Norma, thank you for your time today. This was great.
Thank you. I appreciate it. It's like I said, it's you definitely have a big audience, and I appreciate that. And it's a lot of value for me. At the end of the day, I'm just trying to reach agents. And we have AEP coming. I would rather be able to train a bunch of agents during August and September than wait till October 1st, right?
Yep.
So it's like, let's get it done now. And so, I mean, it's definitely a game changer. And if you're the only one in your area that knows anything about drug savings and you actually start doing the presentations that one that's out and the one that's going to be out, you're going to stand out from everybody else. And as we know, first one in ends up being the biggest. So if you want to be serious about growing your book of business and you want to be serious about getting leads, I'm giving you the path at $50 a month. I guarantee after October 15th, it's probably going to double. Because at the end of the day, it's like, you know, just that next presentation is worth so much and you're going to get it for free.
I love it. I love it. Last question I have for you, and then we'll let you go. What, if anybody had any questions about the program, what's the best way that somebody can get in touch with you?
Well, they can always email me. I always say go to the website first because I spent a lot of money to do 2 sales videos that I paid for professionals to actually come in and do. So it kind of explains the different programs between the tips presentation, because that is separate. So what I tell people to do is don't come in unless you know something already about prescription drugs and savings. Don't just buy the presentation up front. Join the university first and kind of get your feet wet and you know, ask questions and do some studying. Then when you're ready to give presentations, then go and buy that. But that's a good source. So it's www.strategies, the number 4. So it's strategies 4 rxsavings.com. And then that's going to explain a lot. You'll see on the top part where it says find an agent. That's valuable too, because of course, I have to keep in mind that the website is a consumer facing website. So as I'm sending, when I'm talking to medical facilities, they're sending their patients to that site. They can then hit find an agent, put in their state, and it'll pull up all licensed agents who are university members in their state. So you're going to see that. So that's a potential free lead as well. But then towards the bottom, it'll tell you a little bit about the program, and the sales videos are on there. And I give sneak peeks of what does TIPS presentation look like, as well as what does my database look like. But then if somebody has more questions, you can always hit the contact us and email me, or you can just email me at Norma, so Norma, at your, Y-O-U-R, Medicare pharmacist.com, until I have to change that email.
Guys, we'll link that stuff in the description too. That way, if you guys need to find it, it'll be easy to get. You can copy paste it, anything like that. So again, Norma, thank you for your time. This was great.
Oh, you're welcome, Christian. Thank you.
Guys, if you enjoyed this video, you already know what to do. Like the video, comment your thoughts down below, subscribe for weekly education on helping to grow your business, and we'll be back next time. Thanks, guys.